In this lecture, we're going to discuss a number of different pathologies, typically cardiovascular in nature, and some of which resulting in sudden cardiac death. And it's important for us to understand some of the diagnostic techniques that would be employed, and also some of the signs and symptoms that we may be able to identify so that we can better protect an athlete by identifying the pathology early rather than late. And if we can identify in terms of prevention, then we may hopefully end up saving a life. And so there's some opportunity that we might have to recognize signs and symptoms and make referrals to physicians or cardiologists so that proper treatment can occur. Now, the incidence and causes of sudden death in U.S. college athletes is pretty wide-ranging. And there are a number of different studies, this being one where they assess the U.S. National Registry of Sudden Death in Athletes. And if we look at, in totality, this big picture of why and how sudden death occurs, we will find that a rather large percentage comes from or is considered cardiac in nature. But also, there is a rather large component of sudden cardiac death in sports that is due to trauma. So we're going to spend the next few slides talking about some of the causes of sudden death. And in this lecture, we'll discuss a handful of pathologies and some of the things that we might be able to look for or observe in some of our athletes. Now, this figure is great in that it outlines a number of different ailments: hypertrophic cardiomyopathy, different coronary anomalies, myocarditis, mitral valve prolapse, Wolff-Parkinson-White syndrome, dilated cardiomyopathy, and many others. And if we consider the causes of sudden death in NCAA athletes, there's a rather large number of cases that are confirmed to be cardiovascular. Now, obviously, this particular figure highlights a number of different causes of death, but if we recognize that a large portion of these come from cardiovascular pathology, it may be important for us to encourage athletes to undergo pre-screening, to undergo routine physicals, to disclose if they do have particular ailments, so that should something occur, you can better respond and better address the situation. So I want to start here with Hank Gathers, who has been widely talked about in terms of an athlete that had hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy is essentially enlarged cells of the myocardium, typically on the left side, sometimes incorporating the right side as well. But the problem here is in cardiomyopathy, it's a little bit different than just a typical left ventricular hypertrophy. Because in this case, we refer to this as myocyte disarray. And rather than having a normal heart that really gets stronger and enlarges because it's working more efficiently, it's trying to pump harder because an athlete is engaged in high levels of physical activity, the growth that happens in hypertrophic cardiomyopathy is one where myocyte disarray, which is a disorganized myocardial architecture, is where that condition occurs. And I think you can imagine if we consider the normal framework of the cardiac myocyte propagating electrical activity from the SA node to the AV node, bundle of His, bundle branches, there's a normal propagation of this electrical activity that occurs in a very organized manner. And many times you might hear that the heart is a functional syncytium. It operates as one. And this in large part is due to many of the features of the cardiac myocyte, the gap junctions, the ability for the electrical signal to pass from one area to another. But in this case of the abnormal heart, there's a poor propagation of the electrical impulse. And as a result, there's poor compliance and poor diastolic filling, and leading to poor outflow. And hypertrophic cardiomyopathy is characterized by left ventricular hypertrophy without chamber dilation. In other words, the heart kind of grows in on itself, and it impedes the ability of the heart to fill with blood. Now, we know that if a heart is unable to fill with blood, it's unable to also pump blood out. And so in this case, there may be a rather huge problem in terms of we're not able to get blood pumped out to the rest of the body. The etiology or cause of hypertrophic cardiomyopathy is an inherited intrinsic disease of the myocardium and the multiple mutations in genes encoding for cardiac sarcomeres that are responsible for this disease. And this can be a huge problem, and sometimes you might see this abbreviated HCM or HOCM, some would call it HOCM in an abbreviated sense. But this hypertrophic cardiomyopathy is something that can lead to a number of different problems, including congestive heart failure, supraventricular arrhythmias, mitral endocarditis, thrombus formations, ventricular arrhythmias, and certainly sudden death. And this can be very problematic for the athlete who is seeking high levels of physical activity and performance due to the circulation of oxygen throughout the body. Now, this EKG shows just a patient who has an enlarged left ventricle. And you'll notice the first thing you'll notice is that we have these lines drifting off the screen. These are in our precordial leads. Now, the lines that are drifting off the screen indicate that the R wave is very, very large. And this gives us right away an indication that we might be looking at a patient with an enlarged left ventricle. Now, typically, this massive left ventricular hypertrophy, also in the instance of hypertrophic cardiomyopathy, might occur with widespread inverted and deep T waves. And you see that happening in this figure as well. These large inverted deep T waves, not characteristic or something you may not see on a normal ECG. We might also have P wave abnormalities, let's look up here, which could indicate an intraventricular conduction delay, or if we do some analysis and we look at some of our other characteristics, we might be able to identify something that reflects left atrial enlargement. And we might even be looking at somebody with biatrial enlargement, both left and right atrial enlargement. So these changes that we see on the ECG are often in terms of changes that we would see in the electrical activity of the heart given the increase in muscle size. And this example shows a very large heart such that it's almost initiating or causing some deviation as a result of its size. So certainly it can be very problematic. I want to introduce you to the second disease here. I'm going to talk more about our athlete that you see on the screen, but we have another condition called anomalous coronary arteries. And it may be, in fact, one of the main causes of sudden cardiac death in military recruits. Is atypical origin or path of at least one of the coronary arteries. Now, if you ask the athlete, he'd say, this wasn't really something that was on my radar. By definition, really, these variants occur in less than 1% of the general population. But they may be frequently associated with other major congenital cardiac defects. And they may be, in some cases, independent. They may be an isolated finding. But oftentimes a patient will present with a history of chest pain or syncope, oftentimes triggered by exercise. But in this case, they may have and present with a normal ECG. So if we look at anomalous left coronary artery, one that originates from the right side of the right sinus of our artery, we can identify the number of issues that may occur. And we might have an anomalous left coronary artery from the pulmonary artery, which might be the second most common. See, the issue here is that we may actually be delivering deoxygenated blood to the left ventricle as a result of this anomalous coronary artery. We might have problems with the positioning of the artery such that it may be angled in a manner in which it almost like a garden hose kinks at the origin of the coronary artery and compresses the valve and therefore doesn't allow blood to flow through. So here would be an example of this anomalous left coronary artery where we see it, instead of arising as it should from the aorta, we now see it arising from the pulmonary artery. And so instead of serving the heart with this nice oxygenated blood, we're serving the heart with deoxygenated blood. Now that obviously is going to result in tissue death because of the nature of the heart to consume upwards of 70% of the oxygen that it's fed. So if we're feeding it deoxygenated blood to begin with, there's certainly not going to be enough to go around for those tissues that are involved. Now we can also have right and left origins of this coronary artery, and you see here, if we have this anomalous right coronary artery, based on its location, the way that it bends and curves coming out of the aorta, it may actually cause a kink and therefore be unable to serve that portion of the heart. So anomalous right coronary artery coming from the left sinus of the aortic trunk can cause some significant problems there as well. Now, Herb Pope, the athlete that you saw there on the screen, made a huge comeback after this near-death experience following a post-workout collapse. And anomalous coronary artery complications certainly result in sudden death in many cases, but can also, if not resolved, yield congestive heart failure, ischemia, and endocarditis to other tissues. So the athlete here, by undergoing some pre-screening, may be able to identify, or a physician may be able to identify, this anomaly. Now, in some cases, a patient may feel fatigue when working out because they're not getting enough oxygen to certain areas where it's needed. They may feel chest pain. They may feel the need for some type of relief. They may have profuse sweating or diaphoresis. And if we have athletes that are presenting with chest pain and chest problems, these are not things to mess around with. We need to get referrals so that we can get analysis of our heart. We also have myocarditis, a clinical syndrome characterized by inflammation of myocytes resulting from infectious, toxic, and autoimmune etiologies. And myocarditis, inflammation of the myocardium, could be from a viral infection, in which we have myocardial destruction and adverse remodeling that can lead to persistent ventricular dysfunction and dilated cardiomyopathy. And in the example of dilated cardiomyopathy, you see an enlarged left ventricle, such that the left ventricle may be able to hold more blood. However, because of its dilation and its restructuring of some of these myocytes, it may be insufficient in ventricular contraction. thereby unable to forcefully pump blood out of the heart. So we may have ejection fraction issues and certainly some problems as it comes to maintaining cardiac output. There was a 16-year-old that died after making a game-winning basket with just a minute left on the clock in overtime. And on his autopsy, he was found to have dilated cardiomyopathy. And in this case, it was secondary to myocarditis. So what began with myocarditis ultimately led to this dilated cardiomyopathy, in which he participates throughout this whole basketball game. And Wes Leonard died from a heart attack caused by dilated cardiomyopathy. So in this case, this non-specific illness characterized by fatigue, shortness of breath, just overall malaise, bad feeling. And so in this instance, whenever we're looking at an athlete with fatigue that's uncommon, having to catch their breath when that's not a typical response, maybe something is going on, something is developing. Chest discomfort is often reported in some of these patients. 35% of patients may actually report chest discomfort. The pain most commonly being described as pleuritic and sharp, stabbing, precordial type pain. Not things to mess around with, things that need to get referral to a physician to get these checked out. So if you've got athletes coming to you indicating new signs, new symptoms, we need to ask the right questions and get referred for appropriate diagnosis and treatment. So the issue with myocarditis is that the myocardial inflammation directly promotes ventricular arrhythmias, which can lead to dilated cardiomyopathy. And as you see there, the second bullet says that this particular ailment rarely presents acutely with this fulminant congestive heart failure secondary to widespread myocardial involvement. So we understand that myocarditis may be leading to other issues that manifest with greater and greater problems. Now this is an example here where we see sinus tachycardia, we see ST elevation in some of our precordial leads, but when we look for some of the reciprocal changes, we don't necessarily see reciprocal changes. And when we try to further investigate, we might see over time, as we see one EKG to the next, maybe even over a period of hours, days, weeks, we might begin to see these transient Q waves develop. And those might indicate some pathologic changes that are occurring within the heart. We have another ailment called arrhythmogenic right ventricular cardiomyopathy. And here we have Antonio Puerta, a Spanish soccer player who died on the field in 2007. This tends to be an autosomal dominant with a variable penetrance, non-ischemic cardiomyopathy that involves primarily the right ventricle. And the issue here is that there's a replacement of myocytes with this fibrofatty tissue, which leads to hypokinesis, or a low movement of the right ventricular wall, thereby reducing cardiac output, again leading to arrhythmias that often originate in the right ventricle. And therefore these players that have this arrhythmogenic right ventricular cardiomyopathy are at high risk for ventricular tachyarrhythmias and sudden death. And we'll look here, somewhere in this area of the screen, the player in white there runs down the field, drops to his knees, and collapses. And you see one of his teammates rushing over to say, look, something is wrong. And in this case, died on the field as a result of this particular ailment. Certainly we see this condition manifest. We obviously need to initiate high quality CPR, push hard, push fast, electrical therapy as soon as we can. therefore hoping to provide as much oxygen to the brain to preserve the tissue so we can get them into the ER to give the best opportunity for survival. So this arrhythmogenic right ventricular cardiomyopathy, 90% will have some EKG abnormality. A lot of times we're seeing the abnormality as T-wave inversion. But we also have this unique wave called an epsilon wave. And the epsilon wave is found in about 50% of the patients with this pathology. And I'm going to show you a picture on the next slide where it's essentially a terminal notch in the QRS complex. And it's due to slowed intraventricular conduction. So these epsilon waves that we see might be localized in some cases to leads V1, V2, V3, deep T-wave inversion, and this distinguishing electrocardiographic pattern of this right ventricular cardiomyopathy may be looking for those inverted T waves, prolonged QRS complex, and then certainly the epsilon waves that we see pictured here on the screen. And the epsilon wave is a small positive deflection. Let's call it a blip. You see a great example here that occurs after the QRS complex happens. Sometimes it's seemingly buried in the QRS complex, but it's often caused by post-excitation of the myocytes in the right ventricle. And it tends to be, epsilon waves tend to be most characterized in the finding of arrhythmogenic right ventricular dysplasia. And so here we see another example of T-wave inversion in V1, V2, V3, epsilon waves in multiple leads. I'll zoom in here so we can see. We see some of these epsilon waves occurring, right? Here's an example. Now in this particular case, the cause of death for Pier Mario Morosini passed away as a result of cardiovascular problem. In the autopsy, it was understood that he also had a rare congenital heart condition, this arrhythmogenic cardiomyopathy. It was the same condition that claimed the life of Antonio Puerta in 2007. And so this does seem to be something that is not necessarily uncommon. We'll look down here. Oh, sorry, right here. And our athlete essentially right in the middle of a match, no contact necessarily, falls to the ground, collapses with cardiac arrest. Again, the issue that concerns me here is we're looking at a training staff that's on scene with somebody who's not breathing and has no pulse. And one thing that we do not see is CPR underway. It's a big concern in this case because we had an athlete who died and we have no CPR in progress. Now I want to present the final cardiac condition here of a player that has a known heart issue. Because this player was diagnosed, they were given an implantable cardioverter defibrillator, an ICD. And the ICD has wires that are linked to the heart. Depends on the ailment that a person has, but it may be sensing in one area and shocking in another. But because this athlete had identified their cardiac abnormality with the electrical system in the heart, this athlete experienced a cardiac arrest. The ICD picked up on that, initiated a shock, and you'll see what happens next. Let's look up here. So our players collapsed And I want you to look at this. See that little jolt? The ICD kicked in. There's a little jolt, you saw that, of the feet. It shocked the heart back into a normal rhythm. He gets up, not really recognizing anything that's gone wrong, asks to continue playing. For good reason, he's pulled out of the game. But we see a number of these issues come up. So recognizing some of these important factors with athletes that come to you with undue fatigue, with chest pain, with unexplained shortness of breath, recognizing that these are not normal variants, especially if new symptoms arise, getting them a referral to a cardiologist, to a physician, to get some diagnostic imaging could save a life. So with that, we'll conclude. Thank you so much for your attention during this presentation.